Hello, my name is Selena Roberts and I'm an occupational therapist who works at specialist medicine and surgical oncology at the Royal Hallamshire Hospital in Sheffield. I'm completing a master's module in contemporary issues in occupational therapy, which has led me to develop an inquiry question around cancer-related fatigue, an area that I actually work within. The National Comprehensive for Cancer Care Network has described cancer-related to fatigue as a persistent subjective sense of physical, emotional and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with normal functioning. The prevalence around cancer-related fatigue suggests that over 2 million people are living with cancer today, and that's expected to rise to 4 million by 2030. In the UK, 91% of cancer patients are unable to live full and active lives. In Europe, between 17 and 90% of patients experience cancer-related fatigue. In the Middle East, between 18 and 90, and the Fatigue Coalition in the US suggests between 76 and 78%. The functional impact of cancer-related fatigue can be very vast. Evidence suggests that there are a number of resulting impairments, for example, physical, emotional, mental, social, psychological, cognitive and behavioural, much like the components allied to occupational therapy. It can in fact impact on activities of daily living, sleep quality, nausea, work, leisure and social facilities, self-esteem, and an inability to engage in activities that they enjoy. Therefore, quality of life is adversely affected. And there's also a very high probability that cancer-related fatigue will negatively affect the participation in healthy behaviours. Over the past 100 years, lifestyles and occupations have changed dramatically, and OT has survived and continued to thrive and flourish because we have always adapted our practice to meet the needs of the people we serve. There are more than 30,000 OTs working in the UK. About 60% of them work in the health service. Historically, we've been driven by theories and models, yet new theories began to emerge to explain and direct our interventions. By the second half of the 20th century, OT had expanded into many new areas and developed a greater understanding of the physical, social environment of the patients and how they impact on health. We have re-emerged with the profession's core philosophy, occupation, and an emerging paradigm and the shift away from the mechanistic approach. At the moment, we're under a huge amount of change. The Health and Social Care Act 2012 was designed to meet the challenges faced by the National Health Service. It's the biggest reform and most extensive reorganisation the service has seen since 1948. With increased demands on hospital pressures and financial constraints, we need joint partnership and integrated care from the NHS, social care services and the independent sector. Because of the critical challenges facing the NHS and social care, the ageing population, the need to keep people out of costly hospital beds is imperative. So to integrate services would be the key, and occupational therapy has the potential to play a decisive part in ensuring the survival of the system deep into the 21st century. Healthcare reforms have impacted on OTs throughout the world, and they have too made opportunities to promote the profession. In the USA, they've started and looked at improvements in habilitation and rehabilitation, creating opportunities to ensure that OTs are continually valued. In Denmark, we see the development of everyday rehab, a service that's very, very similar to our active recovery service in Sheffield. And in Germany, OTs are engaging with primary prevention and health promotion services. In Sheffield, 2 innovative multidisciplinary team schemes have been introduced, and that is the front door response team and the discharge to assess team. Both services have appeared to be very, very successful, and the FDLT was nominated for the Health Service Award in 2014. The discharge to assess service is to be rolled out across other departments within STH. With the ever-increasing, changing and challenging pressures on OT services, it is paramount that we continually take and make opportunities to further enhance our professional development. We can't have an influence over the changes that are introduced by governments on our hospitals, but we can have an influence on some of the visions that are being put forward, such as the survivorship, and I do think that occupational therapy can play a really valued role. OT's distinct knowledge of the significant impact that habits and routines have on individuals' health and wellness will make their contribution to cancer-related fatigue distinct, and we need to explore and understand our knowledge of cancer-related fatigue and design some rehab services to meet the needs of this growing population. Cancer rehab involves maximising a patient's functional independence with physical, psychological, social and vocational functioning, and ensuring that they're able to live a full and active life, health and well-being during periods of change. One way in which we would hope to do this would be to use current evidence and guidelines. So, Delisa, a psychiatrist, he recognised that there was a gap in services, and still today we have unmet needs. 1 in 3 cancer patients have unmet needs. It's under-recognised and under-treated. It's hardly ever systematically asked about. It's the most common and most devastating symptom. Advances in surgical interventions and treatments have resulted in cancer survival rates increasing up to 6 times longer than 15 years ago. However, certain cancer treatments increase the risk of longer-term conditions and can add to other acute and chronic conditions common in older age, and can have devastating side effects, all of which can contribute to serious health and social care problems. There are currently over 2 million people living with and beyond a cancer diagnosis in the UK, and this will increase to 4 million by 2030. The Patient Experience of Care Cancer Survey in 2014 identified that still 1 in 3 patients have unmet needs. Occupational therapy in the CRF management programme. With the evidence and guidelines, we could devise a programme that would help to raise awareness and understanding of strategies that can help, work collaboratively to help patients identify how they are currently coping, promote self-management strategies, facilitate re-engagement with occupations that have purpose and meaning. Some of the guidelines that we would be able to use would be the National Cancer Action Team, National Comprehensive Cancer Network, National Institute for Clinical Excellence, Macmillan Cancer Support, and the National Cancer Survivorship Initiative. Some of the evidence to suggest that occupational therapy education programs work are named here. They agree that education programs teaching relaxation, energy conservation and strategies to manage symptoms of breathlessness all have positive on patients with cancer-related fatigue. Lifestyle management programs have also proved successful. So screening and assessment, we would use guidelines recommended that every patient should be routinely squeezed by using a numeric stage of 0 to 10, and that would determine which self-help strategies the patient would consider. Some of the other considerations that we would need to address would be disease status and history, recurrence or disease progression. We'd need to look at a review of the symptoms, an in-depth fatigue scale, the onset pattern and duration, change over time, alleviating or exacerbating factors, or interference with activities of daily living. Occupational therapists are able to understand the effect of occupational dysfunction and deprivation on an individual and recognise the importance of restoring and facilitating opportunities with the aim of achieving occupational wellness. Since the beginning of OT, engagement in occupation has been valued as a primary therapeutic agent as well as the goal of intervention. While there are few today who would not support this idea, occupational therapists continue to struggle with implementing their beliefs through what we do and how we do it. We need to ensure that we continually promote our beliefs and purpose to ensure we justify our profession, maximising the power of occupational practice. So we would look at all the above strategies there: grading activities, weekly goal planning, relaxation techniques. We would need to take consideration of outcome measures, the brief fatigue inventory, Schwartz cancer fatigue scale, the fatigue symptom inventory, the Lee's visual analog scale, to name but a few. That brings me to the end of my presentation. I do hope you found it interesting and gives you a little bit of food for thought. Thank you.